Okay, so good morning, everybody. So my name is Anat Lahav. I pronounce it like that. It's strange as is. And my topic will be the use of the functional mobility scale, the GMFCS and the FMS in the clinical practice. I know it's a really famous scale and most of you use it, but hopefully I will try to put some extra light that my colleague and I in the clinic are using it for, like, you know, an extra issue. And I will share my presentation. I need Kinesio, I need you to allow me to share my presentation. The host need to authorize me. Okay. Great. Okay. So again, it's how we use in our clinical practice the GMFCS and the FMS, okay, and what we thought it's important to notice and to try to advance. So most of you, all of you know the GMFCS, and I think for who doesn't familiar with it, it's a 5-level classification. The children with cerebral palsy based on their ability, especially walking and sitting. It's here for a long time, since 2007. It was expanded up to 18 years of old. And what else? It's important in this slide. It's really important that when you classify, to classify according to the age of the child, because I found out that some clinicians, here in Israel at least, maybe some orthopedic doctor, doesn't search for the certain age group, so they overall look on the main characteristics that we will see in a minute, and then we can miss thing, because if they see younger child and they doesn't see which age group and what's the certain classification for that age group, they will classify differently, and it has a major impact on decision. That's my take-home message. So when we see the reliability between different sector and family, we can see the family and physiotherapist, that's for Morris 2008, has good agreement of 64% of the children. And if we will jump down to the last sentence, orthopedic surgery and physiotherapy agree exactly on 50% of the children. And that means that when I recommend a child to go for an extra evaluation for orthopedic, or if he go for his regular orthopedic evaluation regarding thinking of an operation or intervention, we must talk before, because if I see the child as a different level, then he will recommend probably different treatment. Okay, so the family and the therapist and the doctor have to agree, comment on the level of the classification. So we are careful before 2 years of old, because we know in that group age it's sometimes difficult to classify correctly, and correctly means that it will be stable over the year. And it's sometimes really, really difficult sentence for therapists, for family, and to see what's going on, what you mean stable? So what's with all the hard work I'm doing? And it's important to know that statistically, at least, the classification is stable. That means that if I'm classified the child for 3 or for 4 or for 2 or for 1, above the year of 2, I see jumping up in notes. So Kinesio, if it's something I need to stop, please stop me, okay? It's a flashing note, okay. So it's stable over the year, and it's complicated to understand. It means that the tool developed like that in every stage of the age, he showed different thing. It doesn't mean that the child or the youth will keep the same position he is now, but it's allow us to predict in some way how we will be acting in a few years ahead. And what it means, we will see in a minute. And just for this table, it is statistically, there is some children that become better, and there is some children that become worse. And statistically, it's the same. So most of the children will keep the level, and some will be above, and some will be decreased. So this is maybe the famous picture of the GMFCS. It's from 6 to 12 years old, okay? So from whom doesn't familiar, we see up to the left, it's classified level 1. The child in between 6 to 12 can run, can climb. Level 2, up to the right, the child between 6 to 12 years old can walk with independent and use a rail for stairs. Level 3, middle on the left, he uses a wheelchair or a walker or another assistive device that doesn't draw up here. Level 4 in the middle of the right, using power mobility or a walker with assistance of a person. And level 5 on the bottom is children and youth. They don't have the ability motorly to be actively independent in mobility, and they use wheelchair. Sometimes they can use power mobility with a great assistive device, so it will not be just a joystick, but maybe a more complicated technologically issue. And so just important, it's important to know that picture, but it's to remember that it's 6 to 12. And when we try to schedule, and everybody can schedule or put a child on this scale, it could be the parents, it could be the teacher, it could be the clinician. Okay, it's not you don't need to be specific. You just need to follow the order. And it is important to classify the current performance. Okay, the last sentence, and to avoid judgment of movement quality. Sometimes we, as a physical therapist, looking into quality of the movement or patterns, so we don't count them. We just see the activity and try to provide prognosis for improvement. And that is really, really hard, because sometimes the children are just between the group. You know, he will have a birthday 2 months from now. He just has his birthday. So how I'm counting that? So, and I really, really know that now he will be improving and I will see the jump because, etc., etc. Don't do that. Give him the level. If it statistically will be from the children that will change the level, and of course up. So it will be great. But if not, keep the level, so we will all talk the same language, okay? And just for mention, the difference between the age, so the child to be classified at 3, it doesn't start walking with the walker, if you remember that picture. So 3 here is using a walker and a wheelchair. To achieve this mobility at 6 or 7 years old, he doesn't start doing it at 2 years. Or 4 years. Sometimes he will reach this activity through the age of 6 years. So he has to work really hard to get there. It's really hard progress for him because of the basic impairment he's dealing with. And a little bit focus on the GMFs4, because we know that when they will be 6 and adult, they could be independent, really independent with the power and mobility. So it's really, really important if the scale is stable, and we are recognized at GMFCS level 4 at the age of 2 to 4, okay? Before, I'm really careful, as I said, but if I recognize that situation in the age of 2, 3, 4, 5, 6, I really, really recommend to set a proper activity participation goal for that child and try from this year to allow them and give them the power mobility. It's really, really important psychologically, emotionally, cognitive. Okay, so if it will be their main activity and main mobility, we should allow them to use it in an early age. Okay, and also it allows us, if we recognize some this level of 4 or 5 in the early age, as a therapist and as the parents, we need to start planning a long-term intervention, a long-term financial program, okay? Because we will need a household that allow power mobility or regular wheelchair. So we need the adaptation. We need to think where it's maybe the best to live in, regarding neighborhood, regarding school. We need to think about hip dislocation and how maybe we can prevent it or lower it or delay the intervention with it, using 24-hour positioning options. So we don't know everything, and statistic is statistic, you know, but we know a lot, and we need to acquire that knowledge, and we need to do correct plan. Although it's really, really difficult to put it on the table, it's our duty as a therapist to give the information and then to come to a decision together. Eventually, the family will be the one that choose for their children, of course, but our goal is to give the right and proper knowledge and maybe to think together and to see what's right for each family. So the take-home message regarding the GMFCS is to remember the stability of the classification, as I mentioned before, and really, really thought of the goal that's its proper goal. And with my students that come when they meet the first CP client, if it's a child in our school or other children with cerebral palsy, I always think, okay, what the GMFCS level you think is showing us, and does he achieve all the goal or all the activity in that group of GMFCS level? And if he has some, you know, gap, that's the correct goal to work on it now. So to stabilize all the ability in this GMFCS level. So I'm using it also as a tool for therapeutic goal, to set therapeutic goal. Of course, if the child doing all the activity in that description, we can really try and to see if we can do like another activity. We don't stop there. Working with the GMFCS doesn't mean I accept that's the definition and doesn't work behind. But this is the start point, as I see it. And from there, we can always go up and see what the child is showing us and if we can do something else. And also, as I mentioned at the first slide, to think about the disagreement, to know there is possible of disagreement between tester, and to talk it out. Don't just count on your letter that said, pick up a phone, and most importantly, talk to the family and think together what that means. Okay, the family need to know the GMFCS like I did. It's really important for their life. So they could be the ambassador for their children also when they see other clinicians in thinking about decision of intervention. The other tool I really like, and many of professionals say, okay, what you mean? I don't know what you mean behind. It's really regular and simple tool. It's called the FMS. It's Function Mobility Scale. And Graham from Australia published it from 2004. So it's also really familiar. And it's classified functional mobility, reference a variety of the distance environments for 5, 50, and 500. It's a simple questionnaire, and it's for me it's genius because the 550 and 500 meter doesn't represent the meter. I don't count the meter. I don't go, you know, with the meter and see what distance the child wants. It represents the environment. Okay, so 500 will be indoor mobility, indoor in small house, in small room. 50 meter will be a large building like a school, okay? And 500 will be the community. So actually, this tool helped me to understand how the child is independent regarding his mobility in a different environment. And with a combination with the GMFCS, it gives great picture of the mobility in participation, okay? So it's also allowed me to document mobility change over time in the same child and record change following intervention. And that was the purpose of the scale as it was published, record change following intervention. It doesn't specific for cerebral palsy, but for cerebral palsy, it's really unique, and we will see in a minute. And also, research find that the tool determine whether the degree of improvement is significant to the patient, and it's also really nice to know that if you see change in this tool, so it's actually does meaningful, and it doesn't just, you know, changing on the scale. So the scale look like that, and it's like upside down from the GMFCS. That means that 6 and 5 show more really more better, less impairment function, okay, running or walking with some difficulty. And 4, 3, and 2 using mobility device, whether it's a cane, crouches, or walker. And 1 is when you don't use the walking for the mobility and you're using a wheelchair. It doesn't matter if you propel yourself or it's a motor mobility. If it's a power mobility or someone push you, it just means that you don't use the walking, and this scale is for the walking. And you also use C for crawling and N for none. So none is some cases 500 meters, but family doesn't use this distance. They have the car, they park, they go in and out, and they don't really use 500 meters in their life. And it does happen sometimes. And so because the big issue is the environment, to ensure answers that reflect the performance, the selecting of the question is important. And the research is suggesting that question. So how does your child travel between short distance? How does your child move in and out of school classroom? And how does your child travel long distance? And what they find that between 5 and 6 rating, 5 and 6 is, you know, the running and the walking with some difficulty. The difference between them are really represent different in capacity. But when we looking for 2, 3, and 4, the difference between them are sometimes due to personality trait and choices. That means that 2, 3, and 4 are not ordinary scale, okay? And it's really confusing. Yesterday evening, I passed through this presentation with my sister, and she does it from the field from rehabilitation. And she said, what do you mean? Of course it represents a different ability. And I say, no, it doesn't, because when you broke your leg and you use wheelchair and then walker and then crouches and can and then walk with difficulty and walk without difficulty, it is represent improvement, okay, after maybe surgery, orthopedic surgery. But for our children with cerebral palsy, the difference between 2, 3, and 4 are sometimes just the choice of the child and the family. Sometimes, and hopefully in most of the case, it's a choice that improves participation. But sometimes clinician and parents see the scale, like my sister, she's biology, okay? And she said, okay, he uses a wheelchair, then he will use walker, then he will use can, then he will, okay? And they push the child to change for walking device to bring him up the scale, but eventually they can diverse or maybe harm the ability to participate, because if it will be so slowly and so unstable, just to put a check V on the can, it doesn't really represent the ability. That's what it's mean by the second paragraph here, okay? So it could represent, but it's not necessarily, and we really, really need to put the focus on to give optimum participation in the community and not thinking just about the device. So if I'm trying to summarize it quickly, we should be, care should be taken and analyzes FMS in an ordinary scale, okay? It's a nominal scale in part, okay? And think about it, and also present it to the family. I know there is family here. Please be my ambassador to that idea, involve the family as much as you can with your knowledge. It will help them make the decision they need to do for their own best family. And the combination of the FMS and GMFCS provide really better understanding of the child, because, and it is so important, happily I run it through, so I have another few minutes. If we can think of a child who is GMFCS 3, that's mean between the age of 6 to 12, he will go independently with assisted device. It doesn't need to be just walker, just wheelchair, just run. I'm working now with an amazing teenager, and to talk about it and to think, I'm not a wheelchair walking, I'm not a walker children, I'm not a can walker, and I'm not an independent walker. I can be all of them. I can walk a little bit independent and touch maybe furniture in room 5 meter. For the 50 meter, I can use can. Sometimes I want to use my walker. For 500 degree, I prefer to use my walker, and maybe in an early age, you will prefer to use a wheelchair. So it's more complicated than maybe we would want to think. So the device doesn't characterize you. It just gives you the mobility in a certain demand situation. And if we can see how we can, or is the slide, so how we can see the complexity and help everybody to recognize that it's not 1, 2, or 3, it could be all of them together, and it's fine. Okay, don't define yourself by the equipment you use. And so I put the F words from the CAN child, I didn't mention before, but also the GMFCS is from the CAN child. I love the website. Really recommend to use his material. Great. So practice make perfect in goal setting, okay? Not in everything else. And when we see the F word on the ICF model, it's help us to see what's really important. It's the fun, it's the friend, it's the fitness, function, family. Okay, so let's try all together, all the clinician, all the family, to talk on a common ground, use the same words, know the material, and coordinate expectation. It's really, really important. What's the expectation for now? And again, building an economic plan for the future, especially for the children that we see